Module 3, Levels of Evidence in Translational Research. Okay, so the purpose of today's module is to describe levels of evidence in more detail, types and scope of translational research in social work and related fields, and then identifying areas of practice in need of translational research. And these are themes that will carry through to the remainder of the semester. Okay, so as you recall from Module 2, we reviewed the COPES process, which is the client-oriented practice evidence search process. And that's a systematic way by which we go about identifying or locating interventions, instruments, measures, other clinical tools that we can then utilize in practice. And this process moves from the development of a well-articulated question all the way through to testing that given practice or intervention on a small scale and potentially adopting it as part of standard practice. As I also mentioned last module, that the third step in critically appraising the evidence, there are many ways in which we can do that. And what we'll focus on now is looking at levels of evidence as a way to appraise the existing research around an emerging practice model or program. And an assessment of the type of research being appraised usually refers to the study design. And included in that is the methodology, the sampling, the procedure, and so forth. So this pyramid represents one way in which we can assess levels of evidence. And again, there are many types of ways that we can assess levels of evidence in terms of the study design. This ranges from level A to level E in terms of rigor or the gold standard. And level A is a meta-analysis or meta-synthesis. And what that means, it's a compilation or a synthesis of multiple studies, usually randomized controlled trials. And for a meta-analysis, we get an effect size. So a size of the effect of that given intervention upon a particular outcome. And as I mentioned last module, we're looking for large effect sizes. So we want to find that that intervention was associated with a significant improvement in a given mental health condition. In real practice, to find a large effect size is not all that common, and we look towards medium effect sizes and so forth as pretty good evidence of an intervention's effectiveness at improving therapeutic outcomes. Moving down from that, level B is well-designed clinical trials with consistent results. So usually these are randomized controlled trials in which individuals are randomly placed into either the intervention group or a control group. And that may be a waitlist control group where that group receives nothing. And if you recall from, I believe it was module 2, I spoke a little bit about the ethical implications of some of these studies or some of these designs. One of them being that, is it really ethical to withhold treatment? However, if they're already part of a waitlist control and they wouldn't necessarily be prohibited from receiving treatment any quicker, then we're really capitalizing on what is already happening in the clinic setting, meaning folks are on a wait list and we're just monitoring their symptoms over time. So the ethics vary according to whether you're purposefully or actively withholding treatment versus whether they're on a wait list. They would be on a wait list for several months. That isn't technically ethical either, but as we also talked about, workforce shortages and other issues make it difficult for folks who need treatment to get it in a timely way. So perhaps there are several randomized controlled trials that show, say, cognitive behavioral therapy is superior to waitlist control in the reduction of depressive symptoms. And if those results of those studies are all saying the same thing in general, then that is a pretty high level of support. Then you move down to level C, and C level study designs include qualitative studies. So qualitative studies are more explorative. They will sometimes, based upon self-report, perhaps, you will describe your change in depressive symptoms or what this treatment has done for you. Usually there's no randomization in qualitative studies. There's very distinct differences between quantitative or randomized controlled trials and qualitative ones. Um, but as a whole, qualitative studies do not tend to be randomized controlled trials. Also in this are randomized controlled trials with inconsistent results. So you may have a set of studies that show contrary results. You would dig deep into the methodology and the analysis to garner some understanding as to why there are contradictory results across studies. But if there's no other explanation, you're left with a level C level of evidence. Level D level of evidence refers to organizational standards that exist within an agency or a clinic regarding a certain practice that has been vetted and peer reviewed and shown to be effective. It may not be rigorous in terms of the study design, but it may be a standard of care that has been adopted at a given clinic because of its favorable results over time. And then finally, the lowest level of evidence is level E, and that's case reports. So the study I mentioned about Marianne Cooper testing cognitive behavioral therapy for ritualistic behaviors, that was a case report. There was a single individual whom she assessed over time. And so in this metric, they would be allotted a level E. Another way in which we assess level of evidence ranges again through level 1 to level 5. Level 1 is the experimental study. So that is the randomized controlled trial or the systematic review of randomized controlled trials with or without a meta-analysis. Now, if we're calculating an effect size across studies, that is a meta-analysis. If we don't conduct an effect size, or if it's not possible to calculate one, then we call that a systematic review of randomized controlled trials. Now, this metric differs from the previous one in that the level 2 level of evidence are quasi or quasi-experimental studies. So those would be systematic reviews where you're not calculating effect sizes, but it includes a variety of study designs. Some of them are randomized controlled trials. Some of them are quasi-experimental, or you may include all quasi-experimental studies. And most of my reviews that I've done several regarding interventions delivered by peers, which are caregivers, trained caregivers who provide support to other caregivers of children with mental health needs. Most of mine have been quasi-experimental studies where I've conducted a systematic review of the literature. I've found maybe 10 or 12 studies that would meet my inclusion criteria, but because of the topic and the funding and a whole host of factors, we have very few randomized controlled trials of peer-delivered work in children's mental health. So that's also a consideration to take into account. Again, it may not be feasible, ethical. There's a host of other reasons why you might not conduct a randomized controlled trial. That's also costly, and that's part of feasibility. So maybe the best level of evidence that you have are quasi-experimental studies. Non-experimental studies, so that's level 3. And those are, a systematic review of a combination of randomized controlled trials, quasi-experimental and non-experimental, or non-experimental studies only. So you may do a single case study, such as Marianne Cooper, and that's not, that is the lowest level of rigor, so to speak. It's non-experimental. It's more explorative. Post-test only studies are also non-experimental. So it's something to keep in mind when you're looking at the evidence that, um, again, feasibility, cost, all these other issues, ethics play a role in what is the appropriate study design. Another consideration that you would want to look at is the evolution of that topic. And if it's a relatively new topic, you might start with an explorative research design. You might start with a study in which you are surveying individuals about a given topic in a very qualitative way. But as you build more research about a given topic, you would then move into quasi-experimental and randomized controlled trials through a research trajectory. Okay, level 4 is opinion. So that is based upon the opinion of respected individuals or nationally recognized expert committees or consensus panels. And that may include clinical practice guidelines and consensus panels. So there are some, for example, I recently worked on a review with some folks about the pathway of adolescent depression treatment in primary care. And so we gathered, excuse me, we gathered any materials available that gave us some sort of guideline or studies. And it was a very interesting enterprise because what we came up with was that sometimes there really isn't any evidence for a particular therapeutic approach or intervention. So, for example, in cases of mild depression, guidelines would recommend doing supportive counseling and a recheck, or conducting an assessment and then rechecking the individual in 6 to 8 weeks. And there's really no evidence behind it. But based upon their own professional experience, experts came together and said, this is the recommendation. We don't have any hard evidence behind it, but we have seen enough and would recommend this course of action. And then the last level is based upon experiential and non-research evidence. And they put case reports here. I would argue that that would be more of a level 3, but that's neither here nor there. So if you looked at this metric, they include literature reviews, quality improvement projects. So especially in the healthcare field, and we'll talk about the different ways in which healthcare agencies can adopt innovative practices and test it on a small scale. The Institute for Healthcare Improvement, IHI, talks about the PDSA process, which is a way to plan, so implement a particular intervention on a very small scale, study it, and then have a course of action. So either adopt it on a larger scale or reassess and retool it. Anyway, that would be included under QI approaches. And then opinion of nationally recognized experts based upon their own experiential evidence. So let's switch gears a little bit and talk about translational science and translational research. And you have a couple of readings about this. The goal of translational science is to accelerate the use of findings from the laboratory into usual care settings, so bench to bedside. And Palinkas, which is one of your readings, talks about how the National Institutes of Health, again, has a vested interest in pushing treatments that have been found to be effective into clinical practice. Otherwise, you are losing tremendous money. Individuals who could benefit are not receiving those effective treatments, and providers are lagging behind in terms of utilization of the best evidence. So there are 2 phases to translational science that we'll talk about and that your readings describe. The first is phase 1 is to apply clinical interventions that have shown to be effective via efficacy and effectiveness trials into real-world settings. And remember, the difference between efficacy and effectiveness in a very basic way is that the efficacy studies are conducted in a laboratory, highly controlled environment. Effectiveness trials are usually conducted within the community or area in which that intervention would be utilized. The second phase of translational science is to facilitate the adoption, so the uptake and sustained utilization of those best practices in real world settings. So, why build a translational science agenda in social work? There are many reasons. Social workers are the de facto mental health workforce, so we are most likely to be the individuals in which persons who need mental health treatment or case management services, some combination of those, but if those in need of mental health treatment are most likely to approach a social worker. Yet we are in the minority regarding mental health services researchers. And as I mentioned in Module 2, there is a very clear divide in social work, or there has been ongoingly, between practitioners and researchers with respect to their training, their professional careers. So there's quite a divergence between them, and that manifests in this statement, because as much as we are the front runners in terms of professional practice, we lag behind other disciplines with respect to research. Additionally, we have a literature on evidence-based practice, yet we ourselves, and this is by no means isolated to the social work profession, it's pretty much across disciplines. We don't know how to facilitate adoption of treatment in community settings. And again, treatments that have demonstrated their effectiveness usually produce superior outcomes, but they are rarely used. Now, this is an important point. When you are transferring an intervention from the laboratory into the community setting, you will likely experience something called a voltage drop, and that's pretty common language in the literature. And what that means is that the size of the improvement isn't as great as you would find it in the laboratory setting. And there are many reasons for that, but with transportation from efficacy to real world settings, you will find that the effect isn't as great. The effect of the intervention isn't as large upon the outcome. However, it still is superior to services as usual. And they usually produce superior outcomes, but they're rarely used. So this diagram might be a little confusing, but basically what I was excuse me, trying to convey is that there's different pathways. So you can conduct efficacy studies which are tested in the lab and they become best practices, and also effectiveness studies which are tested in real world settings also can become best practices. And when we move from the lab to clinical practice, we are moving from basic knowledge to applied knowledge. So we know the intervention works from our efficacy study, but now we want to see whether it can be adopted in a community setting and how it works amongst individuals with diverse needs and so forth. And then in phase 2, we talked about transporting. So this concerns how do we transport knowledge of best practices or effective practices. How are they adopted in community settings, and are they sustained, and how can we facilitate that? As I mentioned in Module 2, the field of dissemination and implementation and your readings for this week have identified multiple factors that are responsible for why there's that blockage between bench to bedside, or from bench to bedside. And some of them have to do with aspects of the organization, so the organizational culture. Is it favorable or flexible enough to adopt innovative practices? Is there supervision, or is training available? Is the culture of the organization supportive of that kind of initiative? Do they allot space for it? Do they allot training time? All of these factors make a difference. There's also provider level factors, so perceptions about evidence-based interventions, and aspects of the intervention itself. So if the intervention is so rigid and inflexible in administration, then it may not be feasible to implement in a clinic setting. So where are we as a field? Good question. So we know that the evidence-based practitioner model or evidence-based practice it's being increasingly taught as the scientific social work model across schools of social work. So that's good. And there's also more emphasis in schools on evidence-based treatments, training opportunities, certification, and the National Institute of Mental Health is very committed to social work and social workers becoming mental health services researchers. In terms of adoption and uptake, we're now taking a very hard look at those factors across organizations, providers, the intervention itself that may facilitate or block, impede adoption and sustained utilization. And you have some readings about that. You have two projects that have in addition to understanding the effectiveness of a given intervention, is also looking at organizational and those other factors that can facilitate or impede uptake. In addition, we have our methodology becoming more sophisticated. So we have hybrid effectiveness trials, which may study implementation factors simultaneously or sequentially, looking at outcomes as well. So the Acri et al. Article that you have, which is a study that's just wrapping up, is pretty exciting because it's simultaneously looking at both outcomes. So did children with behavior problems improve? As well as what were the factors indigenous to the organization and the providers that supported or blocked uptake. So there are efforts being made. It's a very encouraging time and a promising time in social work, but we need more mental health service researchers who are social workers in order to push this agenda forward. Okay, so next week we'll be talking about challenges, issues, and ethical dilemmas in clinical practice. And this module is critical because this content in Module 4 and the readings and so forth will inform your group projects that you'll present during Module 6 and or Module 9. Now, also, you have an assignment for this week of an online post. If you go to the G Suite, you'll notice that there's a chat folder. In that chat folder, there's there's subfolders for each week that you'll be posting. So what I'd like for you to do is, and this is on page 6 of your syllabus, you would select an emerging program or practice model. Now, I understand that you do not have the content yet to map on to what is an emerging practice model or program. So I'm going to use that very liberally. You can choose an existing one. But I'd like for you to walk through the steps and use the literature on heuristics and practice judgment, as well as what we've been talking about in terms of level of evidence, to identify what gaps or needs does that program or model claim to address, what are the strengths or limitations of that program or model, what research has been done on it, and then what are 2 to 3 specific questions regarding the model for other students to address. Okay. So you would go into the G Drive, and in the G Drive there's a folder called Chats, and then within that folder there are subfolders, one for each week. What I will do is I'll post an example in the Module 3 folder for you to get a sense of what we're looking for. Okay, and this will be done each week for Modules 3 through 7. Reach out if you have any questions at all. And I will, again, my example hopefully will make things a little bit clearer.